In this two-part training, we want to explore the road to resilience by looking at how we got to where we are now and where we are going in the area of trauma-informed care. The concept of trauma and trauma-informed care has evolved greatly over the past 40 years. The social awareness that has developed around the effects of post-traumatic stress disorder in the lives of veterans returning from war has extended our general understanding of trauma in the civilian world. In particular, we have seen a nationwide awareness of how trauma has impacted the lives of children and youth in our social services populations. It has also shifted the way we think about service delivery, and it is changing governmental policies and procedures. This awareness has led to new research and nationwide efforts to develop evidence-based practices that can bring real and compassionate healing. Equally important, it has given a voice to survivors to speak up on what is valuable in their recovery. Counting from the Second World War to the present, the United States has been involved in 25 different wars. Consequently, we have witnessed the damaging effects it has had on veterans, their families, and the community after soldiers return home. Research on the complex effects of trauma has led us to a legitimate description like post-traumatic stress disorder to help us understand and treat it. Today, we understand that trauma is an event the individual suffers, but at one time, post-traumatic stress was seen as a personal weakness and was hidden behind a wall of shame. There have been several attempts throughout history to give a name to what we now know as post-traumatic stress disorder. It has been described as nostalgia, soldier's heart, irritable heart, shell shock, and war neurosis. Based on these labels, early treatment was varied, with soldiers receiving only a few days' rest before being sent back to war zones. During World War II, doctors described PTSD as battle fatigue, or combat stress reaction, giving it more legitimacy, but this was not universally accepted by the military or society. In 1952, the American Psychiatric Association produced the first diagnostic and statistical manual of mental disorders. It included gross stress reaction to describe symptoms from traumatic events, but even then it was thought that symptoms would go away rapidly. In 1994, the Substance Abuse and Mental Health Services Administration, or SAMHSA, gave national recognition to the concept of traumatic stress in children and adults at the DARE Division Conference. It was the first national conference in which women trauma survivors talked about their experiences. They spoke up about the ways in which standard practices in hospitals trigger memories of previous abuse, creating re-traumatization. In 1998, SAMHSA funded the Women Co-occurring Disorder and Violence Study to generate knowledge on the development and evaluation of the integration of service approaches for women with co-occurring mental and substance abuse disorders, who also had histories of physical and sexual abuse. In 2001, the Center for Mental Health Services, SAMHSA, and several national foundations funded the National Child Traumatic Stress Network to raise the standard of care and improve access to services for traumatized children, their families, and communities throughout the United States. Additionally, SAMHSA established the National Center for Trauma-Informed Care. This organization suggested that every part of an organization should include a basic understanding of how trauma affects the life of an individual seeking services. Traditional service delivery could trigger survivors, and organizational reform is needed to avoid this re-traumatization. Other research institutes, like the International Society for Traumatic Stress, and governmental agencies like the Department of Veteran Affairs, have helped to share information on the effects of trauma and disseminate knowledge to reduce traumatic stressors. As we mentioned, the American Psychiatric Association has played an important role in defining trauma. Diagnostic criteria for traumatic stress disorder has been debated through several iterations of the Diagnostic and Statistical Manual of Mental Disorders, or DSM. Following the first label of PTSD as a gross stress reaction, the subsequent manuals added diagnoses such as the adjustment reaction to adult life, but this was limited to unwanted pregnancies with suicidal thoughts, fear linked to military combat, and prisoners who faced a death sentence. In 1980, the third DSM revised criteria for PTSD to reflect current research. A big aha moment occurred when the psychiatric community finally recognized that PTSD was relatively common. It publicly stated that about 4 out of every 100 American men and 10 out of every 100 American women will be diagnosed with PTSD in their lifetime. In 2013, the 5th issue of the Diagnostic and Statistical Manual no longer lists PTSD as an anxiety disorder. It can also be associated with other moods, such as depression or anger and reckless behaviors, and not just anxiety. This has placed PTSD into a new category of trauma and stressor-related disorders. The first 4 manuals and the extended version of the 4th had a dramatic evolution in the recognition of PTSD. In the most recent edition of the 2013 DSM-5, PTSD is evaluated as a trauma that can occur across the entire lifespan. Unless you are a survivor of trauma, much of our review of trauma-informed care and how we got here can sound very clinical. What brings this up close and personal is the Adverse Childhood Experiences Study, or ACEs. Starting in 1995, Kaiser Permanente in San Diego, California, conducted a study with over 17,000 people on the connection between adult physical and mental health issues and childhood trauma. We will watch a short video on this study and its role in raising the standard of trauma-informed care and resiliency in our lives.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
In the next Trauma Toolbox training, The Road to Resilience, Where Are We Going?, we will explore how trauma-informed care is shifting the paradigms of our nation's business principles and practices.